Uh, so, this is the subject of my talk today is something I came to really only about a year ago. I had been very interested in the general question of the relative positioning of the U.S. and other advanced capitalist societies in terms of health status, and was actually my attention was seized in this matter by a report from the Institute of Medicine. I think it was around 2011. And with that background, and working in a school of public health with issues of inequalities of various kinds are central, I was struck by a lecture I heard at Columbia University about the great future that precision medicine held in store for us. And it got me thinking about the relationship between this new focus and what people in public health are, by history and by commitment, concerned about. So that's the general background, and I actually, it would actually be easier if I had a podium, but I'm going to kind of basically talk a lecture. So, give me, okay. Yeah, it's just hard for me to. So it's now more than a year since President Obama, in his State of the Union message in 2014, declared, "Doctors have always recognized that every patient is unique, and doctors have always tried to tailor their treatments as best they can to individuals. You can match a blood transfusion to a blood type. That was an important discovery. Thank you. Perfect. What if matching a cancer cure to genetic code was just as easy, just as standard? What if figuring out the right dose of medicine was as simple as taking a temperature?" That's January 30th, 2015. As the president noted, his immediate attention was focused on cancer. But the grounds for that presidential announcement were well prepared by an increasing focus on genomics at the NIH. In a JAMA editorial titled "Improving Patient Outcomes with Cancer Genomics, Unique Opportunities and Challenges in Pediatric Oncology," over the past decade, there has been increasing enthusiasm for using genomic data to more precisely diagnose, predict outcomes, and prescribe targeted therapies. Academic leaders in clinical medicine and science have emphasized the sharply focused clinical orientation of the undertaking. A sounding board article in the New England Journal of Medicine thus declared, "We define precision medicine as treatments targeted to the needs of individual patients on the basis of genetic, biomarker, phenotype, psychosocial characteristics that distinguish a given patient from other patients with similar clinical outcomes. Inherent in this definition is the goal of improving clinical outcomes for individual patients." That's all a quotation, but focus on the goal of improving clinical outcomes for individual patients. Without much ambiguity, the leadership of the NIH has also noted the centrality of transforming clinical care. Harold Varmus and Francis Collins wrote in the New England Journal of Medicine, "What is needed now is a broad research program to build the evidence base needed to guide clinical practice." But even the rather offhanded efforts to link precision medicine to population well-being is explicitly focused on the individual. It is a remarkable indication of the power of this new idea, the purchase it has, and maybe simply following where the money is, that the Nation's Health, which is the monthly official organ of the American Public Health Association, had a front page story which was really an editorial that said, "Public health prevention to play a role in precision medicine," in which the director of human genetics at UNC Chapel Hill said, In the public health sphere, the near-term gains are pretty clear. They will come from our ability to identify those individuals in the population who unknowingly harbor substantial risk of a severe but preventable disease. And finally, in this regard, the director of the Office of Public Health Genomics at the CDC itself has said, the concept of precision medicine may therefore be valuable for efficiently targeting preventive strategies to the specific subset of the population that will derive maximal benefit. Speaking of tobacco, he went on to note, recent data suggests that using genetically informed biomarkers of the speed at which people metabolize nicotine could lead to personalized smoking cessation. I have to tell you, when I read that, it was hard. I actually found it hard to believe my eyes. We have known a lot about what has led to tobacco cessation in the United States. It has to do with changing the availability of smoking to young people. It has to do with banning smoking in public settings. It has to do with increases in taxes on cigarettes. That has transformed smoking so that now less than 18% of Americans smoke. It is not a specific genetic intervention that is needed. So that is a vision of how does this genetically focused treatment perspective, kind of informed by the NIH, what does it say about what really ails America and its children? In January 2013, the National Research Council and the Institute of Medicine issued its report, U.S. Health in International Perspective, Shorter Lives, Poorer Health. The report ranks the United States as last among peer nations in health status and compares it unfavorably to 17 peer countries at almost every stage of the life course. The United States has higher rates of heart disease, injuries from motor vehicle accidents and violence, sexually acquired disease, and chronic lung disease. Americans lose more years of life to alcohol and other drugs. The United States had the highest incidence of AIDS and heart disease, and it has for decades experienced the highest rates of obesity in children and adults and with diabetes from age 20 onward. Only those who survive to 75 escape this pattern. That is, if you make it to 75, you do well. Indeed, so pervasive was the American shortfall that the report referred to the American health disadvantage. That is, merely being an American put you at a disadvantage comparatively. I'm going to return in a moment to the issue of children, which I think is especially interesting given the way America distinguishes itself and what the implications are for the future going forward. 6 months after the release of the report by the IOM, the U.S. Burden of Disease Collaborative, headed by Chris Murray, published the State of U.S. Health 1990 to 2010 in JAMA, which stated, for all mortality-based metrics, the U.S. rank declined between 1990 and 2010 to 27th or 28th among 34 OECD countries. Citizens living in countries with substantially lower gross domestic product and health expenditure per capita, such as Chile, Portugal, Slovenia, and South Korea, have lower mortality rates than those in the United States. Two years later, in 2015, the National Academy of Sciences issued a report on the growing gap in life expectancy by income in the United States. For males born in 1930, the life expectancy of the top quintile at age 50 was 5.1 years longer than the lowest quintile. For males born in 1960, the gap had widened to 12.7 years between bottom and top quintiles. For women, the same study showed the gap at the bottom had grown from 4 years to 13.6 years. Finally, I mean, this is sort of a grim characterization of where we stand. Finally, between 1999 and 2013, mortality in midlife among white non-Hispanics, the all-cause mortality had increased by 134 per thousand for those with a high school diploma or less. Those with some college had seen no rise in death, and those with a BA or more had seen death rates fall by 57 per 100,000. All of this accounted for by suicide, drug and alcohol, what is called drug and alcohol poisoning, chronic liver disease, and cirrhosis. Let me turn briefly to the story involving children, because I think it's a very telling thing that we fail our children so totally, and that it doesn't become a matter of a sense of national outrage. Here again, I want to briefly summarize what the IOM found. If you look at the age group 0 to 4, the United States ranked 17th in neonatal mortality, 17th in infant mortality, 16th in low birth weight, and 11th in stillbirths. When compared to the other countries, Sweden had a infant mortality rate of 2.5. Italy had a death rate of 3.6. Netherlands had a death rate of 4.2. The United States had a death rate of 6.7. That is 2.5 times that which prevailed in Sweden and Japan. If you look at the age between 5 and 19, age group 5 and 19, overweight girls, U.S. Again was last. Overweight boys, the U.S. was 16th. Adolescent births, and this is important in terms of child mortality, adolescent births, we ranked 17th. Days of life lost for females, between 5 and 19, we ranked 17th. Days of life lost for males, 17th. The report noted that the rate and pattern of death in the United States, 12% was comparable to that of sub-Saharan Africa. Two important factors in infant and child health, adolescent pregnancies and maternal health, were at a U.S. disadvantage. Finally, the U.S. has the highest rate of child death due to negligence, maltreatment, or physical assault. Among 17 peer countries, the rate of violent deaths in the U.S. among boys 1 to 4 exceeded OECD averages, have exceeded those averages since the 1960s. The same is true of unintentional injuries, deaths in boys and girls. So that's the background against which someone like myself, who works in public health, comes to the issue and the enthusiasm about precision medicine. How much of what I've reported to you can be accounted for by Americans' remarkably inequitable healthcare system, which even after the achievements of the Affordable Care Act stands in stark contrast to the systems of other democracies? To this question of the role of the healthcare system itself in perpetuating these inequalities, or being at the foundation of these inequalities, the Institute of Medicine was remarkably candid. It said it has nothing to do, its analysis found that it had nothing to do with healthcare systems, unequal as they are and in need of repair as much as they are as well. At the heart of the matter, I think, are the multiple ways, and again, this reveals my background in public health and my commitment to understanding the social roots of disease. The background lies in the deep and pattern of inequality in the United States. We need to say something about this transformation. It is the notion of inequality has become part of our political discourse recently, in part driven by a remarkable the events of Retake Wall Street, et cetera, so that the notion of the 1%, whatever else was said in those demonstrations, the notion of the 1% caught on. The United States is now more unequal than at any point in the last 100 years. The inequalities actually have dramatically grown. There was a period after World War II, about 2 or 3 decades, when the inequalities were shrinking. From 1970 onward, the inequalities have galloped. Those profound changes in the social structure of American society, unspoken of politically, really, for years, decades, has something fundamentally to do with the lives people lead and the experience they have. It seems hard to understand why white working class men who have suffered huge declines in what they can expect from life, job security, income, etc., the only way to explain increases in suicide, alcoholism, drug use is something to do with the conditions under which these men live. And that, it seems to me, is something which really stands outside the story told by those invested in precision medicine. And this is, nothing about this is new. We have known for years in the careful studies of Great Britain what inequalities mean, the Whitehall studies, the Black studies, studies that looked at the British civil service and found that at every level of the social gradient, those one step lower did worse than those one step above them. One doesn't have to be a socialist or a social democrat or a radical to understand that there's a fundamental truth here that we are failing to apprehend. The editor of JAMA wrote about a year ago, "It is unlikely that the patient-centered medical home or other emerging trends in medicine, such as the use of big data, personalized medicine, or the emphasis on value versus volume in payment, will solve the problem of disparities in health and healthcare and achieve equity, unless the surrounding conditions that patients return to every day in their lives, poor housing, violence, and poverty, change." Now, I don't want to minimize. I mean, there is a long history in public health, a standoff between those who feel that clinical medicine makes a huge difference and those who believe that social transformations really drive population well-being and that clinical medicine is really secondary. There is a huge debate about that. I don't want to enter that debate. When I am sick, I want to go to a doctor who gives me the best medicine possible. If I were to have cancer, I would want a cancer treatment targeted to my cancer. I think every one of us would. That is not the issue. The issue is not what we want from our doctors when we are sick. The issue is what we want from our society in terms of the expectation that we will get sick, or that we will die, or we will have shorter lives. And to that question, I think precision medicine has virtually nothing to say. Indeed, the most reflective and sober advocates of precision medicine are very careful about what they promise. What is interesting is that sober reflections are overshadowed by grandiose statements. I think to get a movement going, to get enthusiasm going, it may be inevitable that grandiosity is part of the political strategy, but it stands in sharp contrast to what precision medicine and indeed what genomics can give us in the short term and maybe even the near term. At my own university, the President Bollinger, has embraced precision medicine with extraordinary enthusiasm. At the medical school last year, 8 chairs for senior faculty researchers were endowed, focused on precision medicine. Now, in the scheme of things, $40 million isn't a lot of money. But it seems to me that a moment when we're confronting the health consequences of grave social inequalities, that 8 chairs were endowed in precision medicine, and that none of that money came to the School of Public Health is itself telling. So I'm left with a deep question, and I really want to turn it back to you. Why do you believe that at this moment precision medicine has become so central a focus in the biological sciences? Why at this moment has the scientific leadership of medicine taken this turn? And with what implications of this turn for health and disease in the United States? Let me conclude, because I really want to bring you into this conversation. Let me conclude with a side that captures the difference between what precision medicine agenda sets for itself and that which follows from a public health perspective. There is a cover of a report from the President's Advisory Committee on Precision Medicine. Which arrow? Enter. I'm sorry. Enter. There it is. This is the cover of the President's Commission on Precision Medicine. You'll notice that there are a population, an interesting population in the background. Someone with a cane, an older woman, someone who's wearing an African-American haircut, someone in a wheelchair, a soldier, and then there's the one stepping forward. And precision medicine is focused on the one. I would reverse this picture. And I think the fact is that in public health, the focus is those in the background. And the worry is that thinking that we can resolve our problems by many ones, I refer to it as an illusion. The question is why that illusion has taken hold with such force at this moment. Now I want to hear from you. Thank you.
So,
Please.
The slogan of precision medicine and patient-centered care seems to have gone forward at about the same rate. And in your view, and maybe in the public's view, what do you think the relationship is between the two?
I don't know. I want you to tell me why you think it's happening.
Well, from my perspective, I can see much more application and much more focus on social determinants of health from a patient-centered care perspective than from a precision medicine, which you so clearly articulated is really mostly focused on genomics.
Right. But my sense is that even patient-centered care focuses, it can allow us to say, if you really care for this patient, you'll begin to understand. People involved in social medicine do take care of patients. So you really begin to understand the worlds within which they live. So in a way, it is the kind of, it has the potential for being the progressive side of clinical care. And again, I don't want to minimize the importance of clinical care. But when you look at when you look at the data and the changes over time, our genetics haven't changed over decades, whatever. Something is happening in America, and it is not good. Yes, sir.
There's, in part, I think there's an inordinate preoccupation with cancer.
Mm-hmm.
And I think a lot of the perception of this precision medicine is that it's going to be a treatment for cancer. Mm-hmm. And because that's so widely feared, I think that people have grabbed a hold of that and become a very high-profile hope that they're going to be able to treat cure.
So when I first met you said you were from the biological sciences. So what do you think that even the predictions in terms of cancer are well-founded?
Well, I think the scientific predictions are cool, and I'm just saying that the public perception of cancer is so out of scope with the actual risk that this has been latched onto as the potential cure for cancer. If you look at the ads on the television from the Cancer Treatment Centers of America, they're just talking, all they're talking about now is they're going to do a genomic profile and come up with a treatment for you.
Yes.
So I have to admit, I'm a practicing physician, and so.
Thank you.
And I don't argue, I don't argue with your general premise that precision medicine will not solve our broader public health problems. There's no doubt one can't rely on precision medicine to solve the problem. I can explain to you a little bit why precision medicine or personalized medicine is now so commonly discussed. It has to do with actually the maturity of the evidence base for management of almost every single chronic disease or acute disease that we have. Through actually NIH funding primarily, we now have actually instances where a given treatment for a common condition actually doesn't appear to work the same in different subgroups of patients, just even by something as simple as age, whether or not you have diabetes or not, whether or not, and to me, that movement of evidence-based medicine is actually part of precision medicine, just even applying existing evidence base actually a trial for that person. That trial did not exist 10, 20 years ago. But now, just to give you a sense of how slow and how fast things are, there wasn't actually a trial for diabetes management showing the benefits of lowering sugar until I was a resident in the late 1990s. So we were actually flying by the seat of our pants. Since then, there have been 4 or 5 trials, actually now showing confusing information, flips back and forth. So I think actually, if you're ever a patient, you would like us to solve these problems so that you can get the right treatment at the right time. So it has to do with the maturity of medicine. It probably coincides with also the Human Genome Project, and the completion of the Human Genome Project, and now you have this wealth of, we've basically had too much information, and we're just trying, the field of medicine is just trying to figure out how to do all of that. It is not going to solve, income inequality. It's not going to solve, smoking. It's not going to stop people from smoking. It actually might help in some areas of addiction. But so that's kind of the history of medicine. The history of medicine is evolving at the same time. I don't know if anyone has thought about the clash that public health, precision medicine, the financing of precision medicine how all that will collide. Not enough people have actually thought about that.
Well, that's the conversation I'm hoping to open, and I do it, and it's very important to do it, recognizing that I'm not a nihilist, and I do believe in that medicine matters, but that it seems that we have to try to, we need a little less hubris in medicine, and a little recognition that our lives. The goal is to prevent us from becoming patients, not to, has to be that. Of course we want, if we didn't think that medicine mattered, then we wouldn't have struggled for close to a century to have a more equitable healthcare system. But we have to understand the limits. Yes, sir?
I do see this as an outgrowth of the Human Genome Project, because the Human Genome Project really hasn't lived up to any of the hype that surrounded it when it started. And this is now a way of maybe resuscitating it and saying that there was some value to it. But I wonder, I didn't know about what was happening at Columbia, but I hear much less about precision medicine this year than I did last year. And now the talk is about the Vice President's moonshot against cancer. Has precision medicine gone out of style already?
It would be interesting to track the extent to which it was not even a fashion, but a fad. But I will tell you that the people who make these big decisions at Columbia, I don't think do things impulsively, and someone. Just the way Obama didn't make this decision without advice. Getting 4 lines into the State of the Union message is a deeply political process. For him to have embraced this means something very powerful was going on. Colleagues of mine who are much more NIH dependent than me say that if you look at the investment in research involving genomics compared to other fields, there is a clear disproportion and a clear indication of where the scientific leadership of the country believes we ought to be going. So, and the moonshot itself seemed to me like yet another, as if we never heard about the war on cancer. And the moonshot is just another image of it is stunning, actually. And it's understandable why the vice president made this statement, given the fact that his son died. But I am perplexed. What is perplexing to me is the silence about the other side of the story. If you add it up, actually there was an interesting article in the Times this week about, because it appeared that the gap between white and black deaths has begun to narrow, though blacks still die in large. And the numbers, one of the people interviewed said, if you added up all the millions of lives lost because of these disparities, just to look at them, it would be a stunning picture. These are not, statistical lives sound, unimportant, but they are, the lives lost, the years lost are in the millions, over years. And people talk about, they talk about social inequality as though it's only a matter of whether you have a more decent rather than a basic place to live. And there are lives at stake. And it is, one other thing I will say about the public is, because public health is, in America is largely a grant-driven enterprise in most schools of public health, there's a desperate search to figure out how we can be part of this. Sometimes it produces oxymorons like precision public health. And you could understand if you were a dean of a school of public health and you saw this is the direction things are going in, you want to say, oh my God, this will destroy us. But, sir.
It strikes me that these are conversations taking place on different planets. On one planet, you've got a medical establishment that is starting to get a maturity in the answers to questions that have plagued people for a long time, sometimes more or less coherently, starting to make real progress, have achievements, a positive sense of going forward momentum, which Americans love when they love things that are positive. So people want to get behind that. That's a good thing. That happens. And as you point out, that these processes develop their own momentum very quickly, and as soon as people say, oh my God, that's where they're giving me grant money, more people rush to that side of the boat, and the grant money comes, and more things are found, and more progress is made, happiness evolves. On the other planet, you've got nasty, crummy, goopy political issues that the country can't begin to get its head around. It can't pass a budget. It can't pass a transportation bill. It can't begin to think about how do you deal with inequality in health and housing and you name it. The country is at best split down the middle with people arming themselves intellectually and virtually on both sides of that conversation. Comparing these two is just, it's not even apples and oranges, it's grand pianos and kangaroos. It seems pretty straightforward to me. What the problem is, the question is, what do we do about it? Because the analysis that we laid out more or less explicitly is certainly correct. The core problem of American health, but tons of other things, is inequality. And it goes back to the founding principles of the country and the fact that we revel in inequality is a great thing. So how do we address that? That seems to me to be a real challenge.
I think in part the task of someone who has the privilege of being in an academic position is to resist the hype, to cut through it, and it's a version of something that academics have taken seriously for a long time when they've taken these things seriously, of speaking truth to power. The problem is you become very unpopular if your dean is trying to raise money for precision something and you say, what does this have to do with public health? It sounds like the same old tune, Bear. I think it's troubling. And it's troubling that someone at the CDC would use the example of smoking as an example of what precision medicine could do with, and I'm a big believer in clinical interventions of various kinds to help people give up smoking, including e-cigarettes. But I don't think the answer is going to be, we're not going to solve the cancer problem and the smoking problem with a genetic or genomic discovery. Yes, and back.
This past October, I went to the American Public Health Association's annual meeting, and their biggest focus income inequity, and in order to raise people up that have less, giving them equal treatment doesn't justify everything. Sometimes you need to give them more. So I would think if there was to be any effect precision medicine could have is focusing on these people that, let's say they live in poverty, they're afraid of doctors, they don't have access to get to a hospital, then I think it's almost to some degree a social experiment. Like, how do you get these people engaged in their health? How do you give them access in order to put them on an equal footing when it comes to healthcare? Because right now I think it's not just a matter of what are the health issues that affect people living in poverty and minorities the most. It's how do you even get them to understand why their health should matter to them and how to get access to healthcare.
I don't, America has opened up the possibility with the Affordable Care Act, problematical as many dimensions of it are, and problematic as many of its the processes of implementation have been, given the Supreme Court decision, etc. We have a long, long way to go on that, and I don't want to minimize that, and I don't want to minimize. I was having a conversation before this talk about how even the expansion of Medicaid in some places has been a grotesque mockery, with imposing co-payments on poor people, and so I don't want to minimize any of that. And I don't think we should for a moment think that the struggle for, that the requirements of any broad concept of distributive justice means America has a very long way to go in doing the most basic thing that other democratic nations have figured out a way of doing, whether they have plans like the British or like the Dutch or whatever. They've all figured it out. We haven't. And it's not because it's too complicated, it's because our politics don't permit it or inhibit it. I don't want to minimize any of it. But if these data are correct, engaging people in the healthcare system is not going to solve the problem of why we die sooner, why babies die sooner, why we have so many preterm births. These are questions that require us to think about both planets. I think schools this is a unique institution, but I think schools of social work, or who have an investment in the world of social work, however broadly defined, and schools of public health are two of the rare institutional settings in the American academic world where these issues have a home. Believe me, the discourse is very different in schools of engineering, schools of business, and it is, and I think one of the missions we have to have is to protect schools like this, schools that focus on the social constructions within which disease and death emerge in a given society. We have to kind of strengthen these institutions. They represent the counterweight to a very different perspective, and I think it is, and it will require big donors because paradoxically, as important as schools of public health are now, they are in a very, very vulnerable position given the funding structure of the NIH and the fact that almost every school of public health is grant-driven. So that is the relationship between kind of academic politics, broader politics, and the issues that I try to address in this talk. I bet if you did a poll and you asked Americans where they put the United States in terms of what they thought the health of Americans compared to others, I think they would be stunned to see the data that came out of the Institute of Medicine. 17th? It's okay if you're not number one all the time, number one. But, it is to be the bottom of the barrel and to have sunk in over years. I think Americans would find it hard to believe. Yes, sir. Back.
So you mentioned statistical lives a minute ago, and I think it's always been true, probably not just in this society, but pretty much everywhere, that the publicly perceived value of an individually identifiable life has always been much, much, much greater than the value of a statistical life.
Right.
And it seems to me that a large part of the argument that you're making is that that shouldn't be so. But individually identified lives have a very powerful emotional impact on everybody who sees that one life that something could be done for. Right. And it seems to me that what's happening, this precision medicine stuff, is just a way of making more lives specifically identifiable as savable. And that's going to be very hard to argue against.
That's why I understand what you're saying, and I understand, there's a kind of a colleague and friend of mine, Ruth Macklin, once had a philosopher was writing on the question of whether one should use antiretroviral drugs for pre-exposure prophylaxis in vulnerable populations like young women in South Africa, when you haven't yet provided treatment to everyone who already has HIV. And she basically laid out this kind of very careful analysis. She ultimately came out in favor of the saving at a population level, but she talked about the rule of rescue, and that's basically what you're talking about. And the other side, in a way, is the kind of abstract thinking that someone like Peter Singer is sometimes engaged in, where it sounds like if you have a choice between your own child and dozens of strange children, but you have to save one or the other, you ought to save the dozens of strange children, not your own. It seems to me we couldn't live with those we wouldn't be who we are as human beings if we made those kind of decisions. So it seems to me the challenge actually going forward, and it's both the conceptual challenge and a moral challenge, is to figure out a way that we can talk about how important it is to care for people who are sick, to care for them well, to care for them in the best way we can, at the same time that we recognize if we really love that person, really care, our goal should be to make sure that he or she never got sick to begin with. But making that linkage, it seems to me, is very, very difficult. Yes?
So I think in some ways, what you're describing is, to me, seems like a puzzle and a tension between public health and medicine that goes way back. Certainly since, the turn of the 20th century, the progressive era. So I guess I have a couple questions. One is,
I would say I think it's important to distinguish between the public health achievements that come through clinical level interventions and the kinds of things that are hinted at in the data on the broad distribution of illness and longevity. We know that under the Affordable Care Act, something quite remarkable happened. It really went under the radar, and that is all clinical preventive services that were ranked A or B by the Preventive Services Task Force must be covered by every health insurance plan without any co-pay or first dollar coverage. It actually presents very big problems because the task force isn't prepared to make the kind of recommendations that are coverage decisions, and it may make the task force actually more vulnerable because now it's making policy. It used to be able to say, we only evaluate evidence. But that was the architects of that little kind of passage in the Act kind of knew what they were doing. They were trying to push a prevention agenda in medicine. I think, and maybe, your argument that maybe we will get to the broader social context as we take seriously the idea of what it is to do in clinical care, and we begin to recognize the limits. That is, why is it that now, if we reach a moment where 95% of Americans have access to health care, and we're still at the bottom, what is going on here? We might have to begin to address questions about the limits of clinical practice in a way that what the thing about the precision medicine kind of vision is it's like the moonshot in a way. It is an enhancement of the vision that clinical medicine is what will make us well.
Yeah. I mean, I think,
Sorry? Yes. Oh, I'm sorry.
can I just?
Yes, please.
Follow up? I mean, to me, what's interesting about public health, I think today, in comparison to the past, is the public health heyday, in a way, right, is when it was focused on truly population health issues like sanitation,
Right.
clean water. Those were things, if you were rich or middle class or poor, you all wanted clean water, and it was clearly a public good, as well as sanitation, right? I mean, these were great advancements in public health, no question about it. They did so much more than individual clinical medicine could do in terms of improving the health of the population, and it was an easy political sell. Today, if what we need, I mean, Florida, Michigan would argue against what, we still need that. But if what we really need is the social determinants of health, as the woman in the back was saying, it really is a targeted focus on the most vulnerable to help create more equity. So as you're talking about, that's completely different politics in the U.S. That, you're right, takes us completely out of the domain, even of where public health has traditionally been. Although it wants to be in social determinants of health, it's more social work has always been there, right? But sort of, I just, the fact that we're not doing the social determinants of health and it's so politically unacceptable just seems part of a large, maybe it's also Mike's comment about it's the kangaroos, and just like, it's hard to like, how could we ever, why are we surprised at all that we're not focused on it, because we never have been, and it's, you know.
Which is, I'm basically piggybacking on that comment, but part of the problem, right, as a physician, I study precision medicine, and I can do it in luxury because, and when I say that, I mean, we've always been so siloed. I'm not actually taking money from public health. Clearly in a global view I am, but we don't have to in a global view. I try to to one particular center, the NIH, that is focused on clinical medicine, and it's not, we're not cross-talking, and so I think, it's a very interesting example to use. We could really, substitute out any part of clinical medicine, and the big part is we don't talk. And so it's easy to sort of unilaterally hype something up else
Yes.
I wanted to point out that, I don't think you guys touched on this, but the Precision Medicine Initiative does, I think, have a cohort study component to it, which is in theory a public health, epidemiological sort of study. Now, it does have a pretty strong genetics focus, but that's not the only data they're collecting there. So it's possible that that arm of the Precision Medicine Initiative could make contributions to public health in some way.
Believe me, the enthusiasm for that large cohort study is what drives the people in schools of public health into the arms of precision medicine, because the departments of epi and biostatistics say, we're the ones who know how to do this. But of course, and this may be a little unfair, it seems to me there it is public health as handmaiden to precision medicine, not as, in other words, the goals of those vast cohort studies, you know, and organizing them and tracking them is really to enhance the precision medicine initiative, not, it seems to me, to take care of the background. I wanted to mention one thing about the language we used in thinking about these things. Many years ago, a philosopher named Norm Daniels, who built his career really on writing about justice in healthcare, used a very, it seemed to me, a very American argument for why we needed justice in health, or equal access to healthcare services. And he talked about fair equality of opportunity. And it seems to me that what we have begun to learn from the data on the relationship between social inequality and life expectancy or risk of disease, etc., is that if we believe in fair equality of opportunity, which is part of the American ethos, then we are failing because we are not providing equal opportunity to all of those at the bottom. And indeed, one of the remarkable things about the transformation in the discourse is Daniels, after 25 or some years writing about the need to have a just healthcare system, because of the influence of some social epidemiologists at Harvard, has now begun to say that fair equality of opportunity means addressing fundamental causes as well. A very big shift with much more kind of radical implications than simply talking about a more just healthcare system. Yes?
If I heard you correctly, your definition of precision medicine initially went beyond genetics, other individual characteristics, which does open up a lot of public health kinds of issues.
Right.
But the practical definition, it is limited to genetics. The appointments at Columbia,
Right. I'm sure.
say that. And that's, the question is, are there any strategies to get beyond that? Or not? And if not, how can you exploit the precision medicine issues for public health? For instance, there may be, if there are applications of genetics to addiction, should the strategy be to really push in that direction? Because it would seem to me it's going to be very difficult to expand the definition of precision medicine beyond this genetic definition that it's really almost a universal definition.
I mean, there was in that one editorial in the New England Journal of Medicine, they do talk about psychosocial characteristics, but I think that really is stretching it.
Yeah.
There was someone in back who I missed. Yes.
But I just think that we shouldn't be arguing against precision medicine. This is important stuff. It's not all there yet. It'll take a long time. It will take a lot of money, but it's a good thing. The fundamental issue is that public health is not about medicine. It's about tolerance. As always, go back and look at the history of public health. It's made great strides when it was able to get enough political muscle to deprive some people of their
let me just say, I think you're correct that what we need to, I think, be alert to is the extent to which the investment in precision medicine overshadows or distorts the vision of what we need to advance population well-being. And we can say it's very important to make clinical medicine more accurate, more effective, etc. But there is this other story that needs attending to, and I think that I'm less worried about the people who are cautious, who are really careful researchers and scientists who talk exactly about the limits of what precision medicine can be than those who... for me, the issue is to say, whatever precision medicine is, however important it is not public health. And that is a hard thing to say. Yes, back.
So I actually really appreciate when you mentioned social work and the whole discussion, because as you just mentioned, precision medicine isn't public health, but I think that's something that you touched upon, Doctor, that there is a need for collaboration between these three different, spheres of approaching, health and inequality. And for instance, in my situation, I'm a first-year medical student. I'm taking courses at the social work school. And even though we talk about inequality in terms of healthcare access in my medical school classes, if I didn't have classwork here, I would never realize social justice, transformative justice, anything about that is really underpinning, why there's injustice and why is there inequality in all spheres of, our lives. So I guess maybe that could be something to, consider moving forward, how to perhaps increase collaboration rather than discuss the divides between these two fields.
Again, to add on to that, I think the public needs to understand the difference too. I mean, it's exactly what you said. Precision medicine is for medicine. Public health is for health. But in meaning that people need to understand the difference, right? I think people think of a hospital as a place you go to get well. And that's not true. You go there because you're sick and you get well enough to go, to leave a hospital. I know it sounds so funny, but I mean, literally, I think the lay public thinks of medicine as the thing that's driving care, and we know it's not. And I think that's part of these, myths that need to get dispelled. Precision medicine will, in fact, help people who are sick to get a better treatment and hopefully get better. But I agree wholeheartedly, it's never going to solve the incidence of disease, particularly ones that are preventable or close to. But I think part of the problem is just the public perception that all these things mesh together. That money that gets invested in health, gets invested in medicine is therefore invested in health, and making people aware that it's not true, and that these silos are sort of separating out the benefits, will potentially get some traction, because I think the average person doesn't think of it as being separated. We all know it very much is.
Yes.
Maybe you're saying it's difficult not to call this public health or something along those lines. Like there's people who want to call it public health. That's what you're saying, right? And when I think about that perspective, I think about what it's like writing grants. An NIH grant, for example, where there's specific sections where you have, even if you're doing the most basic of science and submitting something to NIH, you have to really sell it, right? In terms of its potential health benefits, in terms of its potential public health benefits. Even if you see it as 10 steps, down the road from the work that you're doing. So maybe that's sort of got to ingrained in some of us, and that we tend to oversell, or people may have the propensity to oversell something like this as being transformed for public health. When really, it's very difficult.
And I think that overselling is not unique to medicine. I mean, I have spent the better part of my academic life involved in doing work around HIV. And one of the things that strikes me at the current moment is some years ago, the idea of arguing for increasing access to therapies and increasing access to antiretroviral preventive therapies was a world without AIDS. And indeed, Hillary Clinton gave a speech when she was Secretary of State speaking about 0 babies born with HIV infection. Now, those are all kind of kind of exciting visions in a way, but they really are, have an element of hype. There's no sexually transmitted disease that's ever been eliminated from the human population, even if we reduce the extent to which it poses, to the extent to which it's a epidemic threat. So, but you know, the language took hold, and now in New York State, ending the epidemic has become the official banner of the public health department. What does ending the epidemic mean? Well, then they modify it in little letters, ending the epidemic as we know it. But I mean, I think that the politics of overstatement as a strategy for achieving what you need to achieve is inherent. I mean, there was a time when Lyndon Johnson once said to some advisors, "Don't give me a range. Ranges are for cattle. I want to know the fact." I think it's something to be alert to. I think we all can fall victim to it, but I think the kind of the lesson of this conversation in some way is that perhaps as important as it is to that the energy invested in denouncing precision medicine may not be well spent energy. The more important thing is to say, if you really are concerned with advancing the well-being of patients with precision medicine, we ought to be equally concerned about making sure that they don't get sick to begin with, and that means that we have to take care of all these people, not simply the one. I actually found this, you could almost, when I first saw this picture, I thought it was a caricature rather than a statement of belief. And I mean, in fact, the person who's the one forward is young and vital. You know, they're old. At least if there had been an old person with a cane that was front and center. It being 73, I'm very aware of these things. So, okay, I think we'll stop. I think this has been a good conversation, and I want to thank you very much.